Hello, this is John Kanellopoulos, and these are my financial disclosures. It's a pleasure to discuss with you the almost 2 decades experience on customized refractive and therapeutic ablations in regular and irregular eyes. I come from the LaserVision Ambulatory Surgery Center in Athens, Greece, and clinical professor of ophthalmology at the NYU Medical School, the Grossman Medical School of NYU University, Department of Ophthalmology, New York City, New York. We have presented this material in numerous meetings in the past. It has been the key material in our older topo-guided university courses done the days prior to the major meetings, Academy, ASCRS, ESCRS, and currently named Customized Ablation courses. You can see on the top right of your slide our last course in San Francisco, California, during the American Academy of Ophthalmology in 2023. And also a course given within the ESCRS in Vienna in 2023 as well. These are my financial disclosures, and several are relevant to this presentation. AJKMD Events is the New York-based company that organizes the custom university courses, and I do serve there as a consultant. I consult for Alcon, what used to be known as Avidro in the past, which is Glaukos, a company that makes equipment for cross-linking. Orca is a company that makes the EBK epithelial removal. IPS Surgical, company that makes dry amnion. Keramit, company that makes keratorefractive, and TEA, company that makes ocular pharmaceuticals and mainly artificial tears. So I need to disclose these with you. Here, my financial disclosures with the Customized Ablations September 9th course that we give in Vienna in 2023. And here's some of my personal background. I'm currently a professor of ophthalmology for the NYU Grossman Medical School, Department of Ophthalmology in New York City, New York. I was the past president for the International Society of Refractive Surgery part, the refractive part of the American Academy of Ophthalmology for years 2016-2017. My training includes a training in keratorefractive with Klaus Dolman at the Massachusetts Eye Infirmary, Harvard Medical School. I completed a clinical fellowship, a surgical fellowship in glaucoma at the same institution, the Harvard Medical School, Massachusetts Eye Infirmary. I had the fortune to work with most of the glaucoma specialists in Boston at the time, David Walton, Drs. Hutchinson and Bellows, Dr. Shingleton, and then on the Mass Eye Near side, Dr. Dreyer, Dr. Netland, an excellent experience in working side by side with the cornea service as well. I had, prior to that, completed a cornea and refractive surgery fellowship with Eric Donenfeld and Hank Perry at the Cornell University Medical School, North Shore University Hospital in New York. And my ophthalmology residency was based academically at the State University of New York at Stony Brook, and clinically at the Nassau County Medical Center at the time, and served at the Northport VA during my residency. I completed the Lancaster course in ophthalmology at Colby, Maine, and my medical degree comes from the Southern Illinois University, where I transferred advanced standing to complete my last 3 years from the National and Capodistrial University of Athens, where I completed 4 years, entered with national examinations, and did not complete medical school in Athens. I transferred into Southern Illinois University Advanced Standing, and my high school education was at Varvakian Model School in Athens, Greece, where I graduated with highest honors. So part of this presentation will be based on the invited speech I gave in the 2022 American Academy of Ophthalmology in Chicago, Illinois, where during the ISRS meeting, the International Society of Refractive Surgery, of which I was president for 2016 and 2017, I had the honor. I was asked to present to our audience my experience in using all possible techniques to optimize exodermal ablations and travel from standard to wavefront-guided ablations, wavefront-optimized ablations, topography-guided ablations, and our latest work with ray tracing, which was initially commercially named Innovize by Alcon and currently named WaveLight Plus, as well as SMILE procedures. And this is what we'll do in this talk. Obviously, my relevant financial disclosures for that talk are present in this slide as well. So let's take a step back and see what the facility of customized ablations is for 2024 in the future. If our goal is to achieve good visual acuity and spectacle independence, so have patients with myopia, myopic astigmatism, hyperopia, hyperopic astigmatism, that we want to aim to make them spectacle and contact lens free. Most technologies available out there today by most manufacturers can achieve this goal. And obviously, when we're talking about the USA, there's only 2 companies that compete with this technology, actually 3 companies. That's Alcon, J&J, and Bausch & Lomb. When we're talking about countries outside the US, there's more technology available besides the previous 3 that I mentioned, to include Schwind and Ivis and Nidec and other new-coming companies. So if our goal is 2020, this is a goal easily achievable by most technologies available today. Now, if we endeavor into not only correcting the refractive error, and we'll call it in our talk low-order aberrations, meaning myopia, hyperopia, and/or astigmatism, but we want to look into the possibility of having patients gain lines of vision. A gain in line of vision is our way of describing the difference between the preoperative best corrected visual acuity, so the best our patient can see prior to surgery with our refraction, compared to the postoperative uncorrected visual acuity. So if there's a change in the visual acuity between these 2 entities towards seeing more lines, then we say the patient has gained lines. If it's the same, the patient has now the preoperative best corrected visual acuity, so has not gained lines. If the patient has less, then the patient has lost lines. So this is lines gained, and if this is our goal, then this talk is very pertinent, and I invite you to observe it and study it. If we are aiming into improving low contrastivity, we know, and we see a low contrastivity graph on the right of our picture looking at several spatial frequencies. The ones on the left represent mainly brighter light conditions. The one on the right represent more mesopic and scotopic conditions. We can see that in this particular trial, this is one of our trials, the preoperative, which is the red line, has improved postoperatively. And this is a new entity in refractive surgery. We have performed refractive surgery for decades with our post-op contrastivity being worse or at best at the same level with preoperative. But it is a new entity that we're seeing visual acuities and visual function in lieu of contrastivity to improve from pre-op to post-op. How is this happening? Obviously by improving low-order aberrations, and some of the entities we'll talk in this presentation. And thus, if we look at low contrastivity as a metric that we aim to improve along with spectacle independence, this talk is relative and relevant. And then last, how do we achieve this? We have to make a step back and get just away from spectacle independence and see laser vision correction as a possible means of improving human eye optics. So look at the whole eye as an optical system and see laser vision correction as an opportunity to improve any inherited misalignments, to make this simple, that nature may have brought in when each person's eye was manufactured during the embryo and fetus state and in their early childhood and adulthood, and improving some of those imperfections along with laser vision correction. I know it sounds very ambitious, very complicated. The middle picture shows ray tracing data, top wavefront data, bottom Scheimpflug tomography data, in the middle interferometry data that can calculate with absolute accuracy, and the device itself can self-test its accuracy. Lower aberrations, meaning myopia, hyperopia, and or astigmatism and axis, and higher aberrations seen in the middle column on the left, with a concept that we'll talk in a little bit later. And obviously on the picture on our left, we're seeing a classic Placido disc-based topography that is used for years now to perform topography-guided ablations. So let's jump directly into some of the specifics of our course. Let's go and look at a potential refractive surgery case. And we're seeing the Placido disc topography. So we saw a nice prelude in the previous slide. And we can all agree that if we ignore all the markings on this particular case, that we're talking about regular with the rule astigmatism. Our topography device reads 1.5 diopters of astigmatism, flat keratometry 42.6, steep keratometry 44.1, and obviously I'm reading the numbers off the top left Placido disc topography. We can see the angle kappa, which is the deviation between the vertex, which is the center of our circles of the Placido-Myers, and the center of the pupil. And this is shown in the red oval circle to be on the x-axis 0.03 millimeters, so 30 microns, and on the y-axis, the vertical axis, 0.028, actually 0.28 millimeters, so 280 microns on the y-axis. So we have significant vertical angle cap on this patient. Thus, this regular astigmatism is not viewed by the patient as regular. Because of angle kappa, the patient views this cylinder as a prism. So this creates for the patient a prism that the patient has to subjectively choose cylinder to compensate for that prismatic effect that the cornea induces in their everyday life. This is why our refraction here, we can see our refraction on the top right being -6.5, -0.5 diopters at 45 degrees, completely different than our topography refraction, which is in the middle oval on the top right, which is -111 at 0 degrees. So we have a 45-degree deviation in the angle of the astigmatism measured by the topographer compared to the subjective manifest refraction. And we have over half a diopter difference in the cylinder measured. Now, which one is correct? Obviously, dynamically, the one provided by the patient is correct, because the patient is trying to compensate for the coma that is being created by the slightly decentered regular astigmatism. And this is the deviation between the center pupil and the visual axis, represented here by the vertex or the first Purkinje reflection from the cornea. Now, this coma is evident on our treatment plan on the far right with the Alcon topography guided platform called Contura in the US. We've used this as a therapeutic tool since 2003, and we've published repeatedly on this technology as a therapeutic and later as a refractive surgery tool. So if we put our refraction at 0, and this is under on the right top, the two oval clinical and measured refraction. When we put a refraction at 0, this is what the topography-guided device will suggest as a treatment in order to reshape the cornea or the anterior cornea curvature, because we're talking about placido reflection topography here, to the cornea vertex. So it's going to attempt to normalize the optics of the cornea towards the visual axis of the patient, represented here by the vertex on the placido disc topography. So we can see that this is significant coma. It's mainly vertical. One may say it's a little bit oblique. And after this is corrected, so if we do a topography-guided treatment, then the patient's refraction should ideally be the measured by the topography device. If we will not do a topography-guided treatment, then treating the subjective manifest refraction will give this patient good vision, probably 20/20, but will not optimize the cornea optics for his visual or her visual system. So this is the whole base of our talk here today. How, besides treating refractive error, we can optimize the optics of the human eye, the cornea here in particular, which is perfectly normal. We have normal, regular astigmatism, and we know that the human cornea is the only part of our human anatomy that is born ready. It should not change throughout our life. And we know this by living in the era of cornea topography and tomography, and being able to assess patients very young, adolescents, young adults, and later on in their lives, and seeing that it's actually the refraction, the subjective refraction that changes, but the cornea, with the only exclusion of ectasias, does not change throughout our life, or changes very, very little. And this is the only part of human anatomy that is born ready. Nice things to remember. So this slide alone describes our introduced TMR concept, meaning modifying your treatment, amount of topography, and axis if you are going to perform a topography-guided treatment based on the measured amount and axis of cylinder by the device. We do not do TMR on treatments that are not topography-guided because we're not affecting the symmetry of the cornea, and thus we respect the value of the subjective manifest refraction, which has been the gold standard for all these years. And we've reported on this in 2016. We presented in many meetings, and it has been the seed behind other technologies, including ray tracing and the Forsythe software version 1 and 2 applied in the United States for the last 5 or 6 years. So this is probably the most important slide of my talk. This is why I'm spending so much time, and I hope I'm not confusing. We'll explain a little bit later. So we'll go on to real world, and we'll show you here, I will show you here our publication from the Journal of Refractive Surgery in the September-October issue of 2005. These are presentations at the American Academy and the ESRS of 2004, where we showed that with topography guided, introduced in 2003 by Wavelight, an independent company at the time based in Erlangen, Germany, as a tool to treat irregular eyes. So on the far top left picture, we can see a small, central but small optical zone from a broad beam laser popular in the decade prior to 2000, enlarged with the topography guided software. And we're seeing how effective this is. We can see the difference on the bottom left of before and after, and that looks like a hyperopic correction. So it was not a surprise to realize that when we enlarged the optical zone in this patient, we created more myopia, because the enlargement of the zone was actually hyperopic ablation in essence. Keep this in mind. We'll talk about this a little bit later. We can see treatments which have become the backbone of our Athens protocol and all the other versions and revisions by colleagues throughout the world since we introduced it back in 2004, 2005. On the second example on the left, which is before and after treatment of a keratoconic ectasia cornea, and we can see these are the topometric indices we can see the drastic improvement of IHD, which is circled before on the left, after on the right, but in general, along with all the other topographic symmetry indices, the IHD, the ISV, the IVA, and the IHA, and the RMIN. And this eye turned from keratoconus stage 2 with the Amsler-Krumai criteria of the Pendicam into no keratoconus. This is a star Athens protocol case. And we can see here the amplitude and the power of topography-guided treatments, taking an irregular cornea and turning it into a regular cornea. And we published in 2007. This is the first paper. Took us a very long time in the Journal of Cornea, the pedestal of innovative cornea surgery. And I'll walk you through this complex picture on the top right. It's a keratoconic eye before on the top left, right next to it after simple corneal cross-linking at the time. This was performed in 2005 prior to it becoming CE-marked. We and Theo Seiler were the only centers in Europe performing at the time CXL, sympathetic treatment at the time for patients who were going to undergo cornea transplantation. And we can see the difference right next to that before and after the CXL with the typical flattening that we still see today of 1 or 2 diopters. The patient was still contact lens intolerant, was still a contact lens impossible to treat patient, so thus a cornea transplantation candidate. So we took the big leap of faith at the time to perform a topography-guided ablation. You can see on the top right to create the bottom left of this synopsis picture, which is drastically improved. The difference is right next to it before the topography-guided treatment and after, which mirrors the treatment plan, while the other eye in the last 2 pictures is worsened throughout the year that we're following this patient. This is a landmark paper in the Journal of Cornea in August of 2007 that opened the door of using topography-guided ablations as a therapeutic tool for ectasia, and laser vision correction, especially surface ablation, was up until then considered a contraindication. Bottom picture is a similar application to a scar, a cornea scar. This particular case was a herpetic scar, but it could be a contact lens related ulcer, an infectious keratitis scar that has created a picture kind of opposite to keratoconus. The cornea looks steeper superiorly, flatter inferiorly, because that's where the scar was. If this is a contact lens intolerant patient, this is another candidate for a keroplasty technique, lamellar or penetrating. We can see how topography guided has made this cornea normal. On the far right of these 3 images, the difference before and after, and we see the drastic irregularity, the difference, which was able to make an irregular cornea regular. And then on the far right, we can see our publication of one of the most impressive patients that I've encountered in our career. This was a helicopter pilot from the fire department of New York City who flew from New York to Athens because at the time we were the only center performing this treatment with post-LASIK ectasia. So we're looking at the far right bottom picture or 4 images. The top left of that simplex is the patient with ectasia, grounded by the fire department because of poor visual acuity and the obvious post-LASIK ectasia. We performed the Athens protocol at the time, and we can see the post-op right next to it. We can see the treatment plan on the bottom left of these 4 images and the difference before and after on the bottom right, and see how the treatment plan and the difference map, all these with Scheimpflug, are almost identical, showing the accuracy of this technology and actually performing what we promised, or what it promises to us, in normalizing the cornea. This patient, to our surprise, went on to become a fighter pilot for the US Navy, thus not only halting the ectasia but gaining visual acuities in the 2010 level, and continuing his life's dreams. Obviously, not every patient is an uncorrected 2010, and we have underlined this in a publication since then. But nevertheless, these examples are shown here to show you the potential and the robustness of these treatments and what they're able to do in a therapeutic platform in these very, very regular eyes that, at least when I trained in cornea surgery, both in New York and Boston, they were contact lens or otherwise cornea transplantation candidates. Of course, wavefront-guided was also introduced as a means to attain better vision. We published in 2006 at the Journal of Refractive Surgery presentations also given by us in 2004 as a therapeutic method in irregular eyes, equally therapeutic tool with a potential to treat irregular eyes, but in a more limited fashion, as wavefront with the wave-light technology at the time had the limitation of not being able to image very regular eyes. For instance, the irregular eyes that I showed you before were not able to be treated with wavefront, with the exception only the one with a small optical zone. The other ones would have been very irregular for this technology to treat. So we used for years topography-guided treatments. We published extensively through our Athens protocol experience applied to keratoconic and iatrogenic ectasia such as post-LASIK. And we advocated through these findings that if this technology can make irregular corneas regular, why cannot we apply this technology that was designed to treat irregular corneas on regular corneas, with aiming, what I showed you in the initial slides, into treating an otherwise regular looking cornea with regular astigmatism but with angle kappa, into reshaping that cornea on the visual axis and making it more symmetrical on the visual axis of the patient. And our theory at the time, when we had started to treat virgin myopic and naive myopic eyes and myopic astigmatic eyes with topography guided, was confirmed by the FDA topography guided trial in the United States that included normal, naive, meaning previously unoperated myopic and myopic astigmatic eyes, that showed that when topography guided was applied in those eyes, there was a very welcome surprise. A big percentage of those eyes gained lines of vision, and these data surpassed all other customized data that had gone through the FDA up till then, and it still holds the record for the highest percentage of eyes that gained lines of vision, meaning their pre-op best corrected, improved to post-op uncorrected visual acuity in lines of vision, being able to be read by the patient in stellar acuity or decimal logmar units, showing us that there's a little secret in topography guided treatments that I think we already know because I gave it away in the previous slide. But this is another landmark piece of data that's available at the FDA website. Anybody can access it. These are obviously accessed at the time that I'm mentioning here, but you're welcome to visit the FDA website and be able to access these data submitted and approved at the time by the FDA, which opened the door for topography-guided treatments to be approved in the U.S. for myopic and myopic astigmatic eyes, and their off-label use in irregular eyes since then. So let's go back to TMR. Now we saw how topography guided proved in the FDA trial by our colleagues there. It was a multi-center study that was supervised by Dole Stulting, a very good and esteemed colleague. Back to a patient similar to the one I showed you before. We're seeing here oblique astigmatism, relatively regular, but let's go back and look at angle kappa, which is very significant in this patient, both for the x-axis and the y-axis. In this case, when we put zero refraction in the topography guided data, we can see that there is significant horizontal coma that the device wants to treat in order to normalize this cornea to the visual axis or the vertex. And this is the reason why, again, we have a big discrepancy between our subjective manifest cylinder on the top line, which is half a diopter at 160 degrees, and our measured cylinder by the topography device if the zero treatment is performed and the cornea is reshaped to be symmetrical to the vertex or the visual axis, where the axis instead of 160 is 18 degrees and instead of half a diopter is 125. So what we had introduced as TMR is, if you're going to do topography guided treatment, increase the cylinder to 1.25 instead of half, to the axis of the astigmatism, 18 diopters, and of course take out some of the spherical equivalent from the refraction that we're going to treat. So instead of treating minus 475, we will treat minus 4.4 diopters. So our spherical equivalent will be similar. So the TMR concept is we revise or we modify the amount of cylinder and the axis of that cylinder in our topography guided treatments to match or approach that suggested by the topography device. And I think this brought really a new frontier in laser refractive surgery. We published our first paper in 2016. There has been a very large number of literature since then showing the advantage of topography guided treatments in naive, myopic, and myopic astigmatic eyes. And I think we'll see later on how this concept has really been confirmed by data of this process being performed automated by automated technology that uses these data that we are, in this particular case, designing manually. So this is our data from our published topography modified refraction case series, and I will point you directly in the center of the slides on percentage of patients that gained over 2 lines of vision. The blue column are the ones that are treated with the subjective refraction, and the green column are the ones that are treated with TMR and topography guided. And 1 out of 3 patients gained at least 2 lines of vision when we employed topography guided or Contura in the commercial term of Alcon and TMR. Our innovation and introduction from our center here in Athens, Greece. The rest of the data obviously show much less residual refractive astigmatism, much less residual topographic astigmatism, which is the base of this treatment. So as I mentioned before, we're using laser vision correction here as a means to also make the cornea more symmetric to the visual function of the patient, which is defined by the patient's visual axis. So we're jumping to our modern era many years later, where we've had the opportunity to be introduced and very fortunate to be the first center to perform ray tracing when it became CE marked in 2019. There was a small hiatus in the research of this technology with the coronavirus years, but in essence, in ray tracing, we're using a very similar concept, and I alluded on this concept a little bit in our first slides. We're using this device, a single device that is able to capture both a Hartmann-Shack wavefront analysis of an eye, interferometry data in the middle of the top right picture, which is the display of this device, and Scheimpflug tomography data in lieu of a Pentacam HR. This is the sitemap device as defined by Alcon. It's in essence a modified Pentacam HR AXL wave by Oculus, and it's transformed by Wavelight Alcon to be able to obtain these 3 measurements. The interferometry data are used to build a 3-dimensional virtual eye and not use the Gulfstrand standard eye for the calculations of the treatment. And then the Scheimpflug data, the tomography data, the pentacam data are used to ray trace 2000 rays from the device, as you can see in the bottom right picture, through the cornea, through the aqueous, to the anterior surface of the lens of the patient. And the wavefront data are used to study 2000 rays based on the wavefront analysis and the three-dimensional virtual eye that this software has created from the retina surface, retrograde through the vitreous, through the lens, to the anterior surface of the lens. So step one, step two, we'll talk about the other two steps in the next slide. So wavefront data ray traced retrogradely from the retina to the anterior surface of the lens. And the last step in ray tracing is measuring the tilt. If we consider the cornea and the lens of the eye as two parallel optical entities for the human eye, and they should be ideally parallel, but they're not always parallel. So the tilt between them is also measured by ray tracing, and we have the ability, besides with the data that it provides, to treat lower aberrations, myopia and astigmatism, to treat higher order aberrations, mainly coma and trifocal, and asphericity, and last, also treat tilt. So laser the cornea in a way to reshape the cornea into a lenticular entity that will be absolutely parallel to the lens of the eye, and thus improving the eye as a visual system, as I mentioned before. Fascinating technology. Let's see how it works in action in our next slides. So this is an example case of ray tracing with a sitemap, and we can see on the top left the refractions measured by the device. And you can see, if you can read these tiny numbers, that the refraction is, the preferred refraction by device is the -515 with minus 0.47 diopters rather, at 161 degrees, with a spherical equivalent of -5.39. So a very, very accurate lower aberration calculation, along with higher order aberrations calculated based on the Scheimpflug and the Hartmann-Shack images. In the middle, the interferometry data that all are used to calculate the ray tracing treatment, which is now called Wavelight Plus by the Alcon family. Now for us, an extra prerequisite is for the patient to have near perfect cornea epithelial maps. We can see the top right picture, and we've published extensively on this. This is with the OptiViewer Visionix Avanti and the Solix device, and we can see how the cornea epithelium in this case is absolutely great. It's excellent, is all green in this particular technology, which is for us also the green light to rely on these data and perform these treatments, and we'll see some data of these treatments further on. So this is an example of 3 months. We're seeing on the top right the actual ray tracing calculation. It's an automated calculation by the ray tracing software that takes into account lower aberrations, higher aberrations, tilt, healing data from the amount of myopia corrected, as well as epithelial remodeling data from a large number of eyes studied. On the bottom left, we can see just the higher aberrations and the tilt that device aimed to treat when we set the refractive error at 0. And at 3 months, proof of concept. We're measuring that patient post-operatively to measure the low and the higher aberrations. And we see that the lower aberrations, myopia and astigmatism, are essentially 0. So we're having proof of concept here that not only the data were measured correctly, but when we look at this patient post myopic LASIK, the device is measuring essentially nil. This is a patient that has achieved 20/10 uncorrected visual acuity, has gained 4 lines of vision. And this is how. This is, for us, and for me personally, the greatest vindication and reward of all the work that we've done these 20 years, because this automated technology came to confirm the Kanellopoulos, if you may, approach to refractive surgery, to customize our treatment, not only to have our patients spectacle free, but at the same time to improve the optical properties of that eye, his eye in particular in this example, to the level of this eye performing far better than it ever did, and it becoming a better visual system for the rest of the life of this patient. Because when cataract surgery comes into play, maybe several decades later, the cornea will be more symmetric to the optical system, and thus an intraocular lens, of course we don't know what lenses we'll be using in 20 years, will be far more suitable and easier to blend in these new modified cornea optics. Little advanced. I hope we're following through. Let's see some more data. So this is another case where we're comparing topography guided versus ray tracing, and we have the example placido disc imaging on the middle top. We're getting the okay by our epithelial maps on the top right. We're seeing the ray tracing treatment on the top left that we used, and on the bottom we're seeing the ray tracing data, which are on the left, and the topography data that are on the right. They're not that indifferent. The big difference is that the ray tracing will also treat tilt, which we were seeing here as 6.92, which topography guided will not, because topography guided just images the cornea of the patient, not the rest of the eye, and does not have the ability to incorporate tilt data that ray tracing does. So in essence, in this patient, the advantage between using Contura or topography guided, which is on the bottom right, and this depicts only the higher aberrations attempted to be treated by the software, to the ray tracing higher aberrations and tilt, we can see the difference, and one can judge whether this is more beneficial for their patient. Okay, how does this science apply to everyday clinical sense? These are our data published on using ray tracing and in myopia and myopic astigmatism, and we're seeing all the wonderful graphs. I'll stay with the middle contrast sensitivity graph, which we showed initially in our presentation, where the post-op contrast sensitivity is better than the pre-op. We're seeing on the top left how tight the attempted versus achieved is in the big spectrum of spherical equivalent treated, from a -1.5 to almost a -9.5. So these are real myopic eyes. We can see the postoperative spherical equivalent refraction, which is mainly 0. We can see the stability after the surgery. After that, we can see the refractive astigmatism, how pre-op is green, post-op blue. So we're really reducing significantly the refractive astigmatism. We can see the snell acuity, pre-op green, post-op blue, and we can see how the post-op stands alone in the 2012 visual acuity level, which is a level that these eyes could never reach even with the best possible refraction. And this really underlines the value of what we're talking about here. 82% of eyes gained at least 1 line of vision. Almost 20% of eyes gained 2 lines of vision, as we're seeing on the top left picture. And on the bottom, again, the comparison of pre-op corrected visual acuity to post-op uncorrected and lines of vision gained. Thus, our publication, the first one with automated ray tracing in 2020, underlying the advantages of this technique in WaveLight Plus. These data come from an investigator-initiated study that we did for Alcan, that we also use the NEI or the NIH VFQ25 questionnaire. It's a standard questionnaire of visual function. We selected these key questions: quality of binocular vision from poor to excellent, pain or discomfort associated with the procedure or after the procedure, to include dry eye symptoms, difficulty due to vision with stairs, steps, curbs, and dim light, and difficulty in driving at night. And we saw that in this subjective questionnaire, but very objectified as far as the data we request from patients, that the score was tremendous, tremendous level of patient satisfaction, and this paper is in review for publication. Currently, our latest work from our center in evaluating ray tracing, not just in visual function data as we saw before, but also in quality of vision and psychometric data obtained by these patients. And here's the multi-center international study that I had the honor to supervise as the medical director. We're seeing here Matthias Maus from Cologne, Chandra Bala from Sydney, Australia, and Ramin Karania from Germany as well. And these four centers performed an international multi-center perspective myopic femtosecond laser assisted myopic LASIK study with automated ray tracing. Among the key findings of this study, and this is a large cohort of patients, this is almost 200 eyes, I will stand by the change in corrected visual acuity, CDVA. You can see that 90% of the eyes achieve the same or better postoperative CDVA by week 1, and 36% of the eyes gain at least one line of vision after 3 months. Data that really underline the data from our center alone that I presented previously. This paper is currently in press for publication. But laser refractive surgery is not only LASIK. Here is our presentation from the 2023 ACRS meeting in Vienna, where we're showing impressive data using ray tracing in PRK. We have reported previously the use of EBK, so epithelial removal, with the ORCA device combined with Bronfenac drops for adequate discomfort relief for the first day, and of course ray tracing for customization of the treatment. And we'll see our impressive data in the next slide. So here is the mini PRK technique. I'm using the ORCA EBK device to manually remove only as much as epithelium needed to fit the ablation and the transition zone. We've of course studied this on the X500 excimer laser in order to achieve the exact diameter, and it does take some practice. You can see how I'm orienting my EBK device in all different directions to remove only as much as possible. Very interesting technique, and it'll heal in 3 days. And here are the data with our ray tracing PRK technique using EBK and Bronfenac. Large cohort of patients. We can see on the top left, this is the 2-day epithelialization. See how impressive. One eye is fully epithelialized at 2 days. And this is because we only remove the amount of epithelium needed to fit the ablation by the X500 excimer laser and the ray tracing technology. Pristine eyes. Remarkable that these patients usually see better right after the procedure than our LASIK patients, making all the disadvantages of PRK kind of diminish significantly, and the two procedures become more similar than dissimilar. All eyes look by 3rd day like the 3rd row of fluorescent stained corneas, and a mag underneath showing how the epithelialization has completed an average 3 days rather than the usual 5 to 6 days without this technique. No pain medications in these patients, no IM medications due to the bromfenac use. A great modification of the PRK that we call mini PRK that has really helped our patients cope with the potential disadvantages of PRK and make this a very similar procedure to LASIK. Of course, the main indication of choosing PRK is a cornea that has an irregular to normal pattern and or thinning, or a family of first degree relative with keratoconus. So we're continuing with this is a presentation from the meetings in 22. Some of them were virtual due to coronavirus. All of our initial outcomes in customized Myopic LASIK with automated ray tracing optimization. And here, using this technology in a completely different context, using it in trying to normalize irregular eyes. So, okay, we're using a technology that has been approved in the EU and is currently under trial for FDA approval. The actual data collection has is completed and has been submitted to the FDA. But we're using this technology not for Myopic LASIK, but from what you can see in the top left picture for keratoconus, in conjunction with CXL, meaning a ray tracing Athens protocol. And this is published in the Journal of Cornea in 2021. And we showed that this technology in mild to moderate keratoconus could be also employed instead of topography guided in order to normalize these corneas in conjunctions with higher fluent CXL and offer normalization of the cornea, improvement of visual function with now two major entities that are different, and we'll talk about these in the next slide. Number one, being able to correct aberrations on the posterior cornea surface, something we could not do with topography guided that imaged only the front part of the surface and assumed that the back side of the cornea was normal and had a total power of -6, and we know that's not true in keratoconus. And number two, be able to treat these eyes as if they were tilted, because that's how ray tracing conceives or perceives better keratoconus as a tilted cornea, with the upper part being tilted towards the retina, the lower part tilted away from the retina, thus being able to treat less in the most difficult area, which is the thin cone area, and treat more in the superior tilted area towards the retina, which is thicker, and having a normalization of the cornea with less tissue removal from the thinnest part of the cornea. Very complicated concept. One has to read this paper to understand it, but I think a very key moment for irregular corneas and keratoconus that may change completely the way we approach them with the Athens protocol or the subsequent modifications of it. So these are our conclusions from our Athens protocol using ray tracing with the Alcon technology. Of course, I'm underlining again, this is off-label. We showed that by using ray tracing, we have the potential of correcting more higher aberrations associated with corneal ectasia. We also are improving human eye optics and their alignment, and the value of this technology is yet to be confirmed by its use by more investigators globally, and confirming these initial data from our center, the multi-center study we were honored to supervise. I personally from Greece, Germany, and Australia, and the US FDA trial. Of course, we cannot talk about customized ablations and not talk about refractive cornea imaging principles, and I would invite you to visit our YouTube channel where a whole 1.5 hour is dedicated to going through cornea diagnostics and how important they are in us understanding the way we can customize laser vision applications onto the cornea based on this different, on this big milieu now of cornea diagnostics being available for us as tools to diagnose first and potentially use them as customization modes for laser vision correction or therapeutic applications on the cornea. And of course, our quest of improving laser vision correction included in Greece back in 2015, 16, and 17 our employment of the only technology at the time and first in Greece to use SMILE for myopic laser vision correction, and we ran this landmark study sponsored both by Alcon and Zeiss at the time of comparing one eye topography guided LASIK with TMR versus the contralateral eye with SMILE using at the time the VisionMax 500, the predecessor of the current VisionMax 800, and we showed that both devices in this landmark paper published in the Journal of Refractive Surgery were very effective in correcting low aberrations, meaning myopia and astigmatism. We can see the graphs here. Very safe procedures, both eyes, with an advantage of topography guided in treating better cylinder. And this is evident on the middle top images, where the left is the pre and post-op cylinder in the LASIK eyes, more blue, meaning less astigmatism post-op, where the SMILE eyes are right next to them, more blue spread out throughout, which means more residual astigmatism in the SMILE eyes. And this makes sense because there's no still dynamic compensation for cyclorotation, thus inability for the device to treat precisely cylinder between the one measured and the one applied by the laser. And I think we allude to this within this paper and the subsequent papers comparing these two excellent techniques. Here, looking another means of evaluating customization. This is our same group, one eye LASIK, one eye SMILE, studied throughout 2 years in just with the metric of cornea epithelial remodeling. And the left column are the LASIK eyes, starting from the same point. Right column are the SMILE eyes, and we can see that yes, indeed, the first 2 months there's more red, meaning more epithelial remodeling with LASIK. But as time goes on, the two procedures start to become more similar, and at 2 years, there's very little difference between the LASIK and the SMILE eyes, really demystifying the initial hope that SMILE will be kinder on the cornea surface, less dry eye, since by concept it is working mainly under the subepithelial cornea nerve plexus. But in essence, this study confirms that the two procedures are more similar than dissimilar in regard to epithelial remodeling, although different patterns, but significant remodeling in both, even 2 years out, confirming in our opinion that the dry eye, the transient dry eye encountered in laser vision correction is mainly a curvature change effect and not cornea denervation effect. And this is confirmed, in my opinion, by this study, also published in the Journal of Cornea these last years. Of course, our quest in evaluating our data is, I think, underlined in this paper. We're looking here with a proprietary software that we have developed in our center that is able to use the 1 week tangential curvature difference maps from the pentacam, and this is the middle picture of the 3 topography pictures seen here, and the difference between that and the pre-op was seen on the far right, and use our software to assess how centered the difference, which is the refractive effect on the cornea from LASIK and SMILE, based on the cornea vertex, on the visual axis, which is aimed by both procedures. So with both procedures, we aim to treat on the vertex. With topography-guided LASIK, it's done automatically by the device. So we compare the two eyes for accuracy in their centration on the vertex. And the data available on the left show that LASIK, with its ability to track and center to the vertex, is far more accurate in treating on the vertex. 130 microns plus minus 62, still a very significant deviation for some eyes. 130 microns is significant, 0.1 millimeters, but still for today significant. Almost 3 times more with SMILE. Obviously, limitation from the application of the device, which is not dynamically doing the procedure, read the visual axis of the patient, because the eye is fixated at the time of the patient interface locking onto the cornea surface. Thus, an inherent disadvantage of any SMILE procedure, and in particular the one here employed with the VisionMax 500 in that group of patients that we studied so much. These data also published in the Journal of Keratorefractive Surgery, showing how interested and deep we are in cornea imaging and customized ablations. So the epitome of our quest in customized ablation, I think, comes with our history in the also parallel use of cornea cross-linking. We started using cross-linking with the PriorVision device in 2003. It was a proprietary, non-approved device that we used sympathetically in corneas that were going to be thrown away or sent to the histology lab following cornea transplantation, prior to the CE mark in the European Union of the UVX device in 2006. So we reported using topography-guided PRK and CXL and ectatic corneas back in 2004 at ARVO, combining them at the same time, not sequential, in 2005, using higher fluence in 2006. At the time that the initial 3 milliwatt per centimeter squared resident protocol was approved in the European Union, we introduced interstromal treatments with femto pocket and higher fluence in 2007 at the ESCRS meeting, using LASIK extra, meaning combination of in-pocket CXL and LASIK in 2008, and using it in hyperopic in 2011, also best paper of session at the time with one of our fellows from the NYU Grossman Medical School in New York City, New York, and also showing that CXL and its ability to make the cornea more resistant to enzymatic digestion in different fluences, and how there's a limitation to how far we can go with UV fluence, probably 30 milliwatts, published in the Journal of Cornea in 2014. The modification of the FS protocol with using a customized CXL device, the KXL2 device by Vidro, which was the predecessor of the current Mosaic device by Glaukos back in 2015, and final, I discussed this before, publishing ray tracing Athens protocol in 2021. And finally, in October 23, an invited editorial from the Journal of Cornea, one of the highest honors for myself in particular as an investigator, where we go through our experience with customized ablation for ectasia and that of other investigators that have used our Athens protocol or have modified it, some in their quest also to treat ectasia with CXL, along with the means to normalize the cornea and improve visual function. So going back to the Athens protocol, this is a picture that I like to discuss, and this is basically, we can see, set at 0, our topography device is trying to treat a keratoconic eye and treats some on the peak of the cone. This is the myopic part ablation in the center of our field here. And the most important part here is that hyperopic arc that we see here, top right on the treatment image with refraction being set to 0, which is trying to make the area between the cone and the hyperopic arc become steeper. So thus we're trying to normalize the cornea by flattening the peak of the cone and steepening the area right next to it. So thus reshaping the center of the cornea. And this is the key concept in therapeutic treatments of the cornea, and of course for our Athens protocol seen here. And this is a summary of the Athens protocol as it is applied today, also described in the editorial in the Journal of Cornea in October 2023. As a first step, we do the topography guided partial for refraction surface ablation. So it's a therapeutic ablation, which is on the bottom left. As a second ablation, we do what would account for epithelial removal. And not so, I know it sounds counterintuitive, but the second treatment does not require that specific tracking. That's why we apply it second. The summary of treatment 1 and treatment 2 is the same, either if you apply one first or the other first. So the second treatment is the PTK to account for epithelial removal. Number 3, mitomycin C, 0.02% for 30 to 40 seconds, and we still do it as we still get haze, despite the fact that it has been reported that CXL reduces keratocytes and may not be associated with scarring. We do see it in Greece and Southern Europe because of the extensive UV exposure that we have, and then are introduced and now applied by most investigators and clinicians globally, higher fluent CXL or accelerated CXL, 6 milliwatts per centimeter square for 50 minutes, and this has been the golden standard for us after climbing up in fluence and coming back, because this, as we will see, gives us the deepest and broadest CXL line as a means to define the effect that we achieved with the Athens protocol. So again, a summary of the Athens protocol as we have introduced and as we're applying it today, both in our center in Athens, Greece, and our center in New York City, New York as well. This is a typical Athens protocol case, pre-op on the left, post-op on the right, on the middle rather, and difference map on the right. And let's jump directly to the right and see that the cone has flattened in the steepest area by 10.3 diopters. And also, please pay attention to the area above that looks gray-blue with a maximum steepening there of 6.9 diopters. So we're taking the image on the left, which shows a significant step between 50.2 diopters steepest and 35.1 diopters flattest. So 15 diopter step being corrected, 6.9 plus 10.3, 17.2 diopters. So this is a 17.2 diopter correction in a very regular keratoconic eye that can only be achieved with a procedure like the Athens protocol. We know CXL alone can flatten the cornea 1 or 2 diopters. A topography guided treatment could improve this irregularity, but not to this extent. And this picture alone underlines the robustness of the Athens protocol, where it uses these two concepts at the same treatment, and in a synergistic way we get such a humongous and drastic improvement in the cornea optics, which is evident in the middle image, where the pupillary aperture now, what the patient sees through is a cornea that's drastically normalized. Fine, it's not a perfectly normal cornea, it still has astigmatism, but the astigmatism looks far more regular than it did pre-op in the far left picture. Another summary of the clinical, the brilliant clinical outcomes with the Athens protocol. One of the cases that, as you can see, was performed in 2015 in our center here in Athens, Greece. Same case, we're looking at the proof in the pudding, the improvement in the topographic indices, and we've reported extensively on this. We have reported in detail in an over 1,000 cases to underline the potential improvement with these cases. And we've shown that the key index that improves is the IHD in the green circle. Pre-op 0.146, norm was under 0.016 to almost 0.029. So for, in summary, from 146 to 29, this is 4 or 5 times improvement. The ISV from 137 to 70, so almost halved the index of surface variance. And then also the IHA, index of height asymmetry, from 34.5 to 7.3. In this case, almost 4 in the Amsel-Krumai criteria of keratoconus to 2. But if we look at the center, we can see the drastic improvement in this patient, contact lens intolerant, a cornea transplant candidate, enjoying with a -2 soft contact lens 20/15 visual acuity. We had underlined the advantages of the Athens protocol in a landmark paper reported in the Journal of Refractive Surgery in September of 2009, where we compared our sequential application of CXL first, topography guided normalization at least 6 months later, actually the earliest 6 months later, to doing them simultaneously at the same time. And we showed at the time that the combined simultaneous procedure has less haze, a stronger improvement in spherical equivalent correction, and a stronger improvement in best corrected visual acuity and uncorrected visual acuity. Landmark paper which has been mirrored by all the work of all the investigators, summarized in our editorial of the Journal of Cornea in October of 2023. And again here, some of the examples, the one I talked about before, that helicopter pilot for the New York City Fire Department. This was in the JRS of 2011, that a paper that I wrote with my friend and esteemed colleague Perry Binder of San Diego, California. We can see the before, after, and difference map mirroring the accuracy of this application with the Wavelight Alcon platform. Of course, nothing comes with potential complications, and we have reported, we published a book chapter on delayed epithelial healing being an issue that needs to be monitored by clinicians carefully. It can result in anterior cornea scarring. Over flattening of the cornea may be a finding later on in Athens protocol cases that can be treated with a second PRK, hyperopic PRK procedure. We've reported this in the meetings of these last 2 years. And then these irregular corrections are very sensitive to cyclorotation. Thus, we need a laser that has very dynamic and specific cyclorotation adjustment, because they're very cyclorotation sensitive treatments. Here again, a before and after in the middle treatment of keratoconus, and the difference map again underlying the drastic improvement of the significant step in cornea power created by ectasia keratoconus in this particular case. We went on to measure in our keratoconic Athens protocol population also psychometric change in life impact, and this was published in the literature as well. This is from the initial ARVA presentation in 2016, and we're seeing that besides the clinical findings that are compelling for any cornea and refractive surgeon, the psychometric indices in quality of life change for this patient is drastic, making this probably the most amount of impact, especially in a population like in Greece, where contact lens use is very difficult because of the weather and environmental conditions, a key element to improving the life of these patients. Other innovations that have come along is the, as I noted previously, the variable fluence topography guided CXL. So here we're using a device. The prototype device was the Avidro KXL2, now called the Glucose Mosaic. It can, and this is not FDA approved, it has been CE marked since 2013 when we started using it as the first clinical center in Athens, Greece, and published the first papers in the literature. As you can see here in the red circle, we have circled that the inner oblique rectangle, we're using 15 joules of energy. The one outside that, 10 joules of energy, and the outer white circle of 7 millimeters diameter, 4 joules of energy, simultaneously with one device in order to focus this on the thinnest part of the cornea and attain a refractive effect by cross-linking in a more calculated way. We've published this in the literature. One of our innovations, very interesting to present it here as well, as also a means of a customized application on the cornea, this time with cross-linking. So we're using cross-linking as a refractive means in a calculated way on the cornea. Again, this is one of our papers. This particular one published in 2014, looking at the corneal refractive power and symmetry changes with the Athens protocol, and how worth reading to really follow the thought process behind of customized treatments used to normalize the optics of the human cornea, ectatic cornea in these cases, but these data apply to normal eyes as well, as we showed in the first slides in this presentation. But remember, cornea diagnostics is the key. This is a medical legal case. I had the opportunity to evaluate it in my New York practice in Park and 61st in New York City. A post-LASIK ectasia labeled case. I evaluated the cases carefully. Obviously, the first signs is that we're seeing inferior steepening. This does look like an ectasia case. What do we want to see more than this? Hold your breath. We'll jump to the next slide. What does the total image of this cornea show us? We're seeing the same picture of cornea curvature underlying inferior cornea steepening, but what we're also seeing is the fact that this is only present in the anterior cornea. The posterior cornea on the bottom right is not ectatic, and the cornea thickness does not coincide, the thinnest part of the cornea does not coincide with the steepest part of the cornea. So by studying this pentacam map more carefully, we're seeing that this is not an ectasia case. This is a decentered mixed astigmatic correction. So this case does not need cornea cross-linking, just needs a topography-guided fix to recenter the ablation. The patient was probably squeezing their eyes during the treatment, moving the cornea superiorly and thus applying the treatment inferior to the cornea, as the tracker was not able to identify that the pupil was eccentric. It was reading the pupil but applying the treatment grossly discentered inferiorly. So this is an example underlying that we need to confirm cornea diagnostics before we jump into the treatment, or the conclusion first and then the treatment of an ectasia, CXL. In my opinion, and this really resolved the litigation case, a topography-guided fix saved the day here. We're very fortunate to be able to apply this and have, again, a happy patient. And again here, remember our cornea diagnostics tomography shown here in a schematic on the left. Placido disc reflection topography devices. We showed many in our slide deck here today in the middle, and a technology that we studied extensively, the Cassini, which images color spot reflections created by LED spots onto the surface of the cornea, and then ray tracing every sample of 3 in order to give us more precise central cornea data than placido disc, an alternative to reflection topography, showing that how 3 different technologies can give you imaging of the cornea in different ways, and we'll see how these can differ clinically in an interesting case in the next slide. So we're closing our slide deck here in Customized Ablations by seeing an example which is kind of given away by the top right picture. This is a lady who I'm seeing for cataract surgery consultation with central cloudy dystrophy of Francois, the Belgian famous ophthalmologist of the 1900s. A very benign cornea finding. Placido disc topography seen in the bottom middle shows little withdrawal astigmatism, but remember, placido disc has a blind spot in the center because it starts to measure right off the center, so between the first and the second mire from the center. So it should not show data in the absolute center because those data are extrapolated. The pentacam on the bottom left is really biased by the cloudiness of the cornea and is measuring a very flat center, and this is an artifact because the Scheimpflug imaging is obstructed by the cloudiness within the cornea created by the central cloudy dystrophy of Francois, showing an artificial flattening of the center cornea which does not really exist. And it is the Cassini on the far right that shows a little bit against the raw astigmatism. The raw data from Cassini shown on the top middle, that is more accurate because it's ray tracing central spots imaged on the cornea in the center of the cornea. Why is it important for this patient? Number one, we like to have post-op patients after cataract surgery with slight withdrawal astigmatism. Should we actually use a Acrosoft aspheric toric T2 with 1 diopter of astigmatism placed on the 10-degree meridian, and we did obtain 20/20 vision with 0.4 diopters of astigmatism with the rule in this patient, and the ability with 20/20 at distance to read as good as J4 at near with a monofocal Acrosoft toric T2 IOL. Our go-to procedure, not particularly relevant for the talk today, but this patient's corneas, an example great to study the differences between cornea imaging and start not only correlating diagnosis from the color mask, but also in regard to the raw data of our slit lamp exam and making the correlation between these different imaging entities of the cornea. Great example. So we will conclude this presentation with one of our star cases with the Athens protocol, before on the left, after in the middle, and difference map on the right, showing the robustness and the specificity and accuracy of technology today to be able to treat a very irregular cornea and get a far more regular cornea afterwards. We talked about this technology and its subsequent technology of ray tracing being able to be applied in normal eyes as well, with a goal not only to treat lower aberrations but also to be able to treat higher aberrations such as coma, tilt, asphericity, and trifold. And very proud to be to have been part and to currently be part of the journey of customized applications in laser vision correction, the great wealth of technology that we have today, the great wealth of knowledge that we have attained, and I hope that all these entities that we talked about can spark an interest in you and your clinical practice and how some of these concepts can make our patients benefit from the technology and our expertise. I thank you very much for your attention. This has been a presentation on customized ablations by Anastasia John Kanellopoulos, clinical professor of ophthalmology at the NYU Grossman Medical School, Department of Ophthalmology in New York City, New York, and medical director at the LaserVision Ambulatory Surgery Center here in Athens, Greece. Thanks so much. This is John Kanellopoulos signing out.